Hello, everybody. We are soon live from the NucMed Academy studio, and it starts right now. So we are inside the Nuclear Medicine Academy today, and also we are streaming this to YouTube and to Instagram to see what's going on and to let you know what we are doing here at the Nuclear Medicine Academy and at Berlin Case. My name is Kai Hermann. I'm a radiologist from Berlin, and our scientific head of the Nuclear Medicine Academy is Dr. Ziad Rishek. He's from Amman in Jordan, and he has recorded a lot of lectures and collected cases that is creating this beautiful academy. And this is also the basis to learn nuclear medicine, to know more about it, to know also very specific details about musculoskeletal, cardiac, and oncologic cases. And Ziad, what did you record recently in the Nuclear Medicine Academy? What's going on?
So first of all, I started the PET-CT course. I recorded 3 lectures. One is just an introduction. It's a very short session. It's an introduction about PET-CT. And we have also a relatively long session about patient preparation. I try to cover every aspect and every clinical scenario that might a physician face when they have their PET patients. For example, if the patient is diabetic, how to do the insulin regimen, when to do the FDG PET, how to schedule these patients. If you have a pregnant patient, and you need to do the PET-CT, usually we don't do it, but sometimes you have to do it. So I try to cover all the different clinical scenarios that a nuclear medicine physician may face. Also, I recorded a parathyroid system-EB scan session. It's a comprehensive lecture. It includes everything that a resident or an early physician, a nuclear medicine physician early in their career. Basically, it's everything that they need to know about a parathyroid scan. And I'm going to add more lectures, especially about general nuclear medicine, because we're getting a lot of questions about those. So I'm planning to do those as well to finish the basic nuclear medicine. We're going to add a bit about CT, physics, and I'm going to continue recording the PET-CT course. So probably we're going to have around 10 or 11, maybe 12 sessions. Basically, it's everything you need to know about PET-CT. So those are my plans for the next couple of months.
That's great to hear. Great to hear. And some of these lectures are already there in our academy, and I believe some of them are already live and are already available in the free version of the academy. Okay, yeah. Great. So you have prepared some cases. I will share the screen, and you let us know what's the first case that you have.
Okay. I have 4 cases or 5 cases. I hope you're going to be able to finish them. I'm going to start with this one. This is what we've been talking about recently, about the myocardial uptake in FDG PET scans, how to spot the abnormal patterns of uptake, because everyone seems to think that the uptake in the left ventricular myocardium is variable. But actually it's not. It follows a certain pattern. So this was a recent case I had, and we found this abnormality in the heart, and it turned out to be a positive finding. So we're going to start with this case. Okay, this is a 62-year-old female, and she was referred to do the PET scan. She had liver masses. I didn't have much more history than that, so she was referred to do the PET as further evaluation. She has a history of type 2 diabetes, hypertension, and both are well controlled. She doesn't have any history of cardiac diseases or coronary artery diseases. So this is, I reconstructed the images in the axial and long axis and short axis and long axis views. This is how nuclear medicine physicians look at the cardiac scans. So this is the left ventricular myocardium, okay? And you can tell that the uptake is suppressed, and we want to see this. We want to see suppressed left ventricular myocardial activity. And when I was scrolling through the case, let me show you just the axial or the short, the vertical long axis images. This is how we look at the heart on a FDG PET scan. This is the left ventricular myocardium. And again, as I said, we want to see this suppressed cardiac activity. And when then you notice this activity over here around the apical segment, or the apex and the anterior apical or distal anterior segments, there is some kind of uptake, moderate or intense uptake. And if you're not familiar with the physiologic pattern of uptake, you might think this is just variable cardiac activity. This is part of the hepatic masses. They were showing intense uptake, but we're concerned with this part for now. It does not occur or fill in randomly. It follows a certain pattern. So we need to learn the physiological pattern of uptake. When a patient is fasting, okay, we don't see any kind of uptake. Usually this happens when we don't see an uptake if the patient is fasting more than 8, 12 hours. And the first segment that starts to fill in the left ventricular myocardium is basically around the basal ring. It's in the anterior basal segment. So you expect to see the uptake or the physiological uptake starts somewhere around here. Then the basal segments of the lateral wall starts to fill in. So we are talking about this region. Let me show you the short axis. And this is the apical region, and we're going to go back to the basal region. So this is around the basal region. And first, we expect to see uptake around the anterior basal segment, followed by the lateral basal segments. Then the septal basal segment starts to fill in. This is how we see on the MIP images the basal ring. After that, the lateral wall starts to fill in, and relatively the septal wall is a bit it starts to fill in later after the lateral wall. It is a bit delayed, and the filling continues towards the apex, and the last segment to fill in is the around the apical septal segment. So when you look at this image, you can see that the left ventricular myocardium, the uptake is suppressed, and you have this focus of uptake over here. So when you see this pattern, this is deviating from the normal metabolic or the physiological pattern of metabolism. You have to suspect that there is an underlying, either it's a hibernating myocardium or you have, for example, an ischemia. So this is what I reported. It is adequate. The left ventricular myocardium is suppressed, adequately suppressed, and there's a focal of uptake or focal area of moderate uptake in the apex and distal anterior segment or wall. And this is deviating from the normal expected physiological pattern. I suggested that the patient should do SPECT perfusion scan, and she needs a cardiac consultation. So 15 days later, 2 weeks later, she came back and we did the SPECT myocardial perfusion scan. These are attenuated corrected images. And in the upper row, this is the short axis. Nuclear medicine physicians are familiar with this image. Here you have the stress, and this is the rest. This is stress, rest. The lower rows, you have the rest, and the upper rows are the stress. So if we start here at the apical region, you can see there is decreased uptake, and this is around the apical segments. Here you have severely reduced uptake and moderately reduced uptake over here, and we're still around the apical segment. So this is moderately reduced, and the intensity, the severity of intensity it tends to get less as we go towards the proximal region of the left ventricular myocardium. And it's when you look at the long axis images, you can see this. There's a focal defect over here, or absent perfusion in the apex and around the anterior apical segment, and it's not reversible. So this is a fixed perfusion defect of severe intensity, or you can say absent tracer uptake. And here you can see it really nice. We don't have an uptake around the apex or the apical regions in the stress and the rest. This is a fixed defect. And this is the polar map. You can see the defect over here. This is the apex, and these are the apical segments. So again, this pattern of optics is sustained in the rest image. So what you have here is absent perfusion in the apex. It's irreversible, it's fixed. It's most likely it can be a scarred apical myocardium or a hibernating myocardium, but because we have a PET image and it is showing uptake around the apex and the anterior apical segment, so this is a hibernating myocardium. So if you learn the pattern of normal uptake on FDG PET scan regarding the left ventricular myocardium, you're gonna pick up a lot of findings like this, and you never know, you might even help the patient in diagnosing a coronary artery disease that they did not know about. So this is how I do my reports. I start, this is that, of course, the perfusion scan. I start with the size of the defect. So it's a small size, or maybe it's a medium size, because we have the apex and the anterior apical segment. It is irreversible. I comment about the reversibility after the size. And then we talk about the severity. So we have here absent tracer uptake. And then we report the location in the apex and the apical anterior segment of the left ventricular myocardium. So this is the summary and the learning points here. It's basically what I talked about the normal metabolic distribution, how it starts and how it fills in. And these are the references. You can check them out for yourself as well. But what we need to know is that the physiological pattern or normal metabolism starts at the thickest part of the heart, which is around the septum and the basal ring. And this is followed by filling in the left lateral wall and then the septal wall. They actually go together, they fill in together, but the septal filling is slightly delayed compared to the lateral wall. And after the lateral wall fills in, the apex is filled in, and the last segment to fill in is the apical or apico-anterior segment. So this is concerning the first case. I like this case because we have the PET finding, and we have a confirmation with the SPECT perfusion scan. So you can see how these findings in the left ventricular myocardium relates to the SPECT perfusion.
Great. So I have a question. You have these SPECT cardiac images, and they usually are presented as a grid, like 8x8 or 6x6. So why is that? Why do we not scroll through the images like we are used to doing it in other cardiac studies?
This is how it's displayed for the perfusion. We have the short axis and we have the long axis. We have the vertical and the horizontal axis because it's based on the polar map and the distribution of activity. So this is basically, we're looking at perfusion in the left ventricular myocardium. We don't have anatomical correlation. So what you're looking at here is basically the perfusion through the coronary arteries into the left ventricular myocardium. But if you do a SPECT CT, if you fuse the images together, you can get to see the cardiac structures like this. But when you're assessing the perfusion in nuclear medicine in general, this is basically the way it has been done for years.
Yeah, it seems like it's for historical reasons. It's like this.
Yeah,
it would be time to change it, right?
I think because we're assessing segments and regions, so probably this is maybe the easiest way to look at it from a nuclear medicine perspective.
Great. Okay. I don't see any specific cases here regarding this case. I wonder what's your next case that you have prepared.
So, okay, before going into the next case, I want to show you this one. I think we talked about this case. There's still no medical history. I'm going to do this later, but this is a 28-year-old male, and he's been complaining of chronic back pain for the past years. I was consulted on this case, so I didn't have much history. He did see a couple of x-rays, and according to the patient and referring physician, there was nothing significant there. So this is the whole body scan. This is the bone scan. And when you look at the posterior projection, you can see that there is a regular uptake around the spine, around the costovertebral junctions and joints. You have uptake here at the tip of scapula. Probably you have uptake around the ischium, and you have this uptake here in the clavicle. So when you look at this, you don't know what you're actually looking at. Is this a bone metastasis? Is it something else? Is it an infection? You can't really tell. And when we did the SPECT CT, so I'm going to start with the axial images. So you have this intense uptake around the posterior aspect of the vertebral bodies, and there are corresponding sclerosis over here. So we have sclerosis, and it's showing intense uptake. This is the tip of scapula. You can see that there is osteosclerosis, and there are erosions as well over here. And if we go up a bit, you can see that there is some partial ankylosing of the costovertebral junctions. I think there was over here, you can see a bit of osteosclerosis as well, and a bit of ankylosing. If you go up, you can see here the medial ends of the clavicles. We have erosions and sclerosis and so on. So this is what this patient has, and let's take a look at the sagittal images. Again, you have the sclerosis at the posterior upper corners of the vertebral bodies, and they're showing uptake. You have here subchondral sclerosis, erosions. So this pattern, let me show you first the sacroiliac joints. We have ankylosing of the sacroiliac joints, or partial ankylosing, and there's surrounding fat surrounding the sites of ankylosing. Am I right?
Sure. This is a very typical case. It's a beautiful case. I will comment on it. But this is full ankylosis with a lot of fat tissue inside the joint space.
And we also have erosions here and sclerosis, also at the ischium over here, and at the pubic joint as well. So this pattern is characteristic or for axial spondyloarthropathy. And when you see this uptake pattern on bone scan, you should suspect an axial spondyloarthropathy. Okay, so this brings me to the case that I want to talk about.
But I guess when we go back to this case, I guess that usually most of nuclear medicine physicians would call it metastasis, and would refer for oncologic workup.
Exactly. Most of these, especially when the request is just a planar bone scan, usually it is for assessing bone metastasis, or they look for multiple lesions. If they see multiple lesions, they think that this is probably metastasis. But when you look at this pattern of uptake, it doesn't really look like metastasis. You have here, if you look at the posterior projection, the uptake is more intense compared to the anterior part. So you have to think that the uptake or the underlying pathology is involving the more of the posterior elements, or the posterior aspects of the vertebral bodies. This is how you should think about planar bone scan. So this case, this was just an introduction, this case, because this is a really nice case. This is a PSMA case. This was a 51-year-old male. He was referred to our hospital for treatment for metastatic prostate cancer. So he had a CT scan and a bone scan, and the CT showed multiple sclerotic lesions that was suggestive of metastasis. they referred him for a bone scan somewhere else, and I didn't have the images. The report was that there are multiple focal uptake of intense uptake, and it was suggested that these are metastatic. So he was labeled as a metastatic prostate cancer patient. He had the scan. He brought the scan on a film. Unfortunately, I don't have images on my laptop, so he had it on a film. But the uptake was a bit similar to this one. So when I saw the images, I suggested that we should do a PSMA scan, because I don't think his workup was informative, and probably it was suboptimal. And this is the MIP of the PSMA scan. This is a fluorine PSMA scan, so we don't have any kind of urinary bladder activity. This is the MIP. And we're going to look at the prostate first. So you can see there's no urinary bladder activity, and we have Polis catheter. This is really nice. This is really helpful. And okay, so this is the prostate gland. And when you look, you have multiple focal areas. You have one over here. This is in the transitional zone. You have an uptake in the peripheral zone. This is the central zone, and it is extending into the peripheral zone. This is in the left lobe. And the good thing is that we have a Polis catheter over here. So we know this is the midline. This is the right lobe, and this is the left lobe. And if we go a bit up, you can see there's mild expression in the central zone, and it is protruding or expanding to the peripheral zone over here. So we have multiple focal areas of intermediate or low to high PSMA expression in multiple segments in bilateral prostatic lobes. We don't have any regional lymph nodes. The rest of the abdomen looks fine. We don't have anything else. Now, let's take a look at the bone, at the spine. And when we look at the spine, if you remember the last case that we just saw, again, we have the same kind of findings over here. And we have some kind of ossification in the anterior ligaments over here, and none of these findings are showing PSMA expression. Now I'm going to show you the axial images of the bone. So here, if you look at the acromion, it looks a bit sclerosed compared to the contralateral side. Let me show you the CT. Okay, so you have here a bit of sclerosis compared to the contralateral side. And if you look at the tip of the scapula again, in the left side, you have sclerosis compared to the contralateral side, and you have a bit of erosions over here. So you have erosion and you have sclerosis. And let's take a look at the spine and the axial images. So you can see the sclerosis over here. Again, the costovertebral junctions and joints. So here we have ankylosing. You have partial ankylosing over here. So this is very characteristic for an axial spondyloarthropathy. This is not metastatic deposits. And here you can see that there is ankylosing. If you scroll through the images, you can see that as well. Here we have ankylosing. Let's take a look at the sacroiliac joints.
Let's stay like this. Have a look at the costovertebral joints again. So this is arthritis of the costovertebral joints. We see a lot of sclerosis and also some erosions, which are quite typical for axial spondyloarthritis. And in fact, the costovertebral joints, they are very specific for axial spondyloarthritis. And I remember one case of our own where there was a patient about 65 years of age with prostate cancer and positive PSMA findings, and they were already planning to biopsy the bone lesions, but at the end it turned out to be axial spondyloarthritis, and we did not do the biopsy.
And here you can see the sacroiliac joints. Again, it's almost identical to the case that we saw. We have ankylosing of the sacroiliac joints. The most important thing that none of these findings are showing any kind of uptick. Even the pubic joint, it is showing sclerosis and erosions as well. So this is this is again characteristic for spondyloarthropathy. These were not metastatic bone deposits. So you should be very careful with planar bone scan, even though when you have these multiple lesions and they're all over the body, you should think of something else, or at least you have to recommend to correlate these findings with anatomical imaging, because not the specificity for a planar bone scan for metastasis, or the specificity in general, actually, it's very low. It's around 40%, or I think even lower than that. So this is how I describe the prostatic lesions. And this is the description for the findings in the spine. And none of these findings were showing any kind of PSMA expression. So in conclusion, we have multiple bilateral intraprostatic hyperdensities. And if you adjust the window, the CT window a bit, you can see that there are hyperdensities. So this is MI2. If you do if you follow the PROMIS criteria, the M is for multiple. We have 0 nodal metastasis, and M0, we don't have any kind of distant metastasis. And the patient, I suggested that they should do the HLBA27, and it was actually positive. He had, I think, according to the dermatologist, he had ankylosing spondylitis. So what you need to learn here is PSMA, as you can see, it overturned the metastatic label for this patient into T2. So instead of just doing palliative treatment or systemic therapy, the treatment can, with curative intent, can be achieved in this case. Planar bone scan, it overcalled it because it's not specific. We just see areas where there is increased osteoblastic activities, whether it's benign pathology or malignant pathology. You just see the bone turnover or the bone hypermetabolism. So it's not always metastasis, and you should always correlate. If you just do planar imaging, correlate or recommend that the referring physician needs to correlate with anatomical imaging, whether it's CT, X-ray, or MRI. And if you have a SPECT CT, then it's much easier to make the diagnosis on the spot when the patient is in your department. So this concludes the second case. Do we have any questions?
So far, I don't see one. I think it's a case that is very much to detail, especially the bony changes. And it's great that we have the combination here of prostate prostate pathology and bone pathology.
Yeah, and we had a positive case with bone scan. So this, when you see this pattern of uptake in a bone scan, think of rheumatological disease or an axial spondyloarthropathy. This is very characteristic on bone scan, especially when you see this uptake here in the clavicle. So what is it doing here? And this uptake here in the tip of the scapula. Why do I see this pattern of random lesions? And why is this pattern of uptake in the spine looks like this? Why is it more intense in the posterior part? Why the costovertebral junctions and joints are showing this kind of uptake? So you have to question the pattern of uptake on planar images.
Do we have a bone scanner from the PSMA? No, we don't have it.
No, it was on a film, so I could get it.
Okay, so let's dive into the next case.
Okay, so this case, this is a knee case. This is, I don't like knee prosthesis. It's very difficult to assess. You have to do a lot of measurement, and it's really difficult to find the any kind of pathologies when the patient is in pain. So about this one, I think it's pretty straightforward. This is a 77-year-old female, and she had a total knee replacement in 2016, which is a good thing because I really don't like doing SPECT CT for knee prosthesis after 6 months or 7 months or even at 12 months. because sometimes you're gonna end up with uptake depending on the prosthesis design, depending on the alignment of the prosthesis. So it takes a lot of time to evaluate these studies. She was complaining of vague knee pain, right knee pain that is located medially, and it does not radiate anywhere. It's increased by movement, especially walking, and relieved by rest. She had no history of trauma. There's no joint swelling, warmth, or tenderness. No history of fevers, and the inflammatory CRP and ESR were not elevated. She did an X-ray. They did not state any kind of abnormality, so she was referred to do the SPECT CT. This is the delayed MIP, and here we have the early MIP. So we can agree that we have a congruent pattern of uptake between the delayed and the early MIP. We have uptake here around the tibial prosthesis, and this is around the tibial plateau, and we have proximally here this focal area. And let's take a look at the planar bone scan. I started to put these so you can correlate with the SPECT CT finding. So you can see that there's an uptake over here, and there is intense uptake in the medial tibial plateau. Now, this is the early phase image. So we have this uptake over here. This is intense perfusion or uptake in the early phase in the medial compartment of the knee beneath at the bone prosthesis interface. We're going to see that on the coronal images. And it is showing intense perfusion in the anterior part and the posterior part of the medial compartment, and it is extending into the central compartment as well. We have uptake here around the tibial tuberosity. This is the coronal images. Again, you can see the same kind of uptake. This is very intense. And here, this is the sagittal. This is just vascular activity over here. You have this uptake here, as we saw in the axial images in the posterior, and we have in the anterior tibial aspect and the tuberosity. This is the axial. Usually we evaluate in the sagittal and coronal, but let's take a look at the axial. You have an uptake here at the patellofemoral interface. And if I remember correctly, she had subchondral cystic. We have small subchondral cystic changes over here. So this is probably early patellofemoral femoral degeneration. We don't have any abnormal uptake around the femoral component. So let's take a look at the coronal images. Okay, it loaded very fast. Very nice. So we have an uptake here in the, as I said, in the medial compartment, anteriorly and posteriorly, and it is extending centrally. Now, when we see this, and this is at the below the tibial plateau at the bone prosthesis interface, so we try to look for any osseous changes on the CT. Now, you really need to look very carefully. Sometimes you really need to be careful to look for subtle osteolysis or osteolytic changes. And you have to adjust the contrast or the window, basically, the CT window. So you can see here, there's a bit of osteolysis. It is very evident here. We have a bit of osteolysis, and it is showing intense uptake. So this is very characteristic for loosening. Okay, and if you look at the subchondral region, you have this sclerosis over here. And if, by the way, if you do an MRI, you're going to find a bone marrow edema over here. You have a sclerosis over here compared to the, if you compare to the lateral part. And here at the tibial part, you have this cystic lucency. It looks like a cystic cavitary cyst. And there is intense uptake around the cortex. I think there was a cortical interruption. I think she had stress fracture, if I remember correctly. There was a bit of cortical interruption somewhere around here. They did a redo surgery. This was actually loose. She had loosening, and if you look at the tibial stem, it is somehow penetrating, or there's some kind of penetration through the cortex. So let's take a look at the sagittal images. Okay. So you can see here there you have a bit of cortical interruption and a bit of sclerosis. I suggested that this is probably a stress fracture because you can see the tibial stem. It is abutting or a bit penetrating through the cortex. And here you have this intense uptake. You can look also for osteolysis. There is a bit of osteolysis over here, but from because of the metal artifacts, it is really sometimes it's really very difficult to see. But you can see that there is sclerosis below the tibial plateau. I'm gonna try to find you have a bit of sclerosis over here, osteolysis over here, and it is corresponding to this intense uptake. So this was actually a loose tibial stem. She did a redo surgery. And one more thing to add, if you look at the tibial stem, one of the measurements that we do is the tibial slope. So basically, you do a line through the tibial shaft. It should be perpendicular to the tibial shaft, and another one through the prosthesis stem. And you measure the angle between when you do the line for the tibial shaft, you do another one perpendicular to it, and you have to measure the angle between the tibial plateau and the perpendicular angle to the tibial shaft. And if this angle is more than 7 or 8 degrees, this is probably you have excessive tibial sloping. And if the plateau is pointing posteriorly, this is posterior slope. And if it's pointing anteriorly, this is basically anterior slope. And it can also be neutral as well. So here it was, I think, if I remember correctly, it was around 11 or 12 degrees. So we have excessive tibial sloping. And this puts, depending on the type of prosthesis, if it's cruciate retaining or cruciate retaining, or if you have a cam that replaces the cruciate ligament or cruciate, if they remove the cruciate. So in this case, this was cruciate retaining. So you have excessive stress on the cruciate ligament, and sometimes the patient can describe that their knee is giving away. They can't really control it, especially during flexion. So this was excessive anterior sloping, and this is how I do my reporting. We have osteolysis and sclerosis in the medial compartment at the bone prosthesis interface, and there was intense early and delayed phase uptake. We saw the cystic lesion. I really don't know what was that. I've never seen something like that, but there was cortical interruption in the anterior cortex at the tibial tuberosity. So it was suggestive that there is a stress fracture over there, and it is supported by this stem, somehow penetrating through the cortex. We also had subchondral cystic degeneration or cystic lesions at the patella at the patellofemoral interface. So this is suggestive of early patellofemoral degeneration. I measure the rotation of the femoral component and the tibial component. It takes a lot of time to do these, but sometimes with the pattern of uptake, it really helps. And if it was an excessive, for example, internal rotation, you see a specific pattern of uptake on the early and delayed phase. And if the femoral component was in excessive internal rotation or external rotation, you see different patterns of uptake. So it really, the SPECT CT basically it picks up the altered bone stress on the prosthesis and on the bone if there is a misalignment. So this is where this modality is really powerful. It's not just about if you have a lucency with corresponding uptake. But for example, I like this case because it's straightforward and you can correlate with this planar images. Not everyone has SPECT CT. And so when you see this pattern of uptake, you can remember the images that I showed you in this case. You can say confidently, this is probably losing in the medial tibial component, especially that is showing intense uptake. You have to be careful because sometimes in some prostheses, this uptake can persist for a very long time, even up to 5 years, even more than that, but it's not that intense. It's usually mild uptake or moderate uptake. It's not that intense. And if you do SPECT CT,
How long did you say can it persist? 5 months or 5
for
years?
5 years, yeah, it can persist for 5 years in the medial tibial compartment. But the thing is, when you do SPECT CT, you would expect the uptake, if it was benign, let's say, it would be confined to a single compartment. So you probably see uptake in the posterior medial compartment. It can extend a bit anteriorly, but this is very intense, and this is involving almost half of the tibial, the bone and prosthesis interface in the compartments. You have the anterior, medial, and the posterior. It's extending into the posterior. So this is very intense. And another thing you should remember, in posterior tibial slope, you can expect to see mild to moderate uptake in the posterior compartment or medial compartment. This is how I divide the tibial part into lateral, medial, and central. Some divide it into medial and lateral, but I think when you do a 3-compartmental model, it's easier. And I think there are published. This division or segmentation is in published papers. One more thing to add, as I was saying before I lost my. When you have posterior sloping, you can expect to see an uptake in the posterior compartment. Usually it's confined to one region and it's mild to moderate. So do not overcall it as loosening. Knee is difficult, but I hope this case somehow it's going to make it easier for the attendees when they face similar cases like this in their interpretation.
There was one question about the rotation that you manage.
Wow.
Manage. So can you briefly explain what would it take you to measure the rotation?
So yeah, okay. It takes a lot of time. I think I can do a session about this and record a session about how to do the measurements. But I'm gonna talk about the femoral component, the tibial. You need to demonstrate it. I can't just do it like this. I need to demonstrate it with proper tools. So in the femoral compartment, what we do is we draw a line that is perpendicular to the epicondyles. Okay, we do a straight line at the posterior part of the prosthesis over here at the condyles, and we do another. We draw another line from the peak of the lateral epicondyle and into the medial epicondyle. It is better to do it through the surgical, the medial tuberosity or groove. This is basically. Let me show you how to find it. Okay, this is basically the medial groove. So you draw a line between the peak and this groove, okay, and you measure the angle between this line and this line, okay. And according to the I forgot the numbers I have. I always look at them, but we're gonna do a session about this. It will make it easier. According to the number that you get and the opening of the angle, it can be internally rotated or externally rotated. Probably I would add the measurements and all that somewhere in these volumes. So this is how we do it. Basically, we draw a line at the posterior part of the prosthesis at the condyles, perpendicular line, and another one here at the epicondyle. The line should start at the peak of the lateral epicondyle, and it should go through the groove over here. This is the surgical line. And if you can't find this groove over here, you can just do a transepicondylar line. So basically, you draw a line from here to here, and you draw a line here, and you measure this angle between them. And the tibia, it's really difficult. It takes a lot of time. So probably I need a workstation to show you how to do it. And the patterns of uptake, it takes a lot of time. So in knee prosthesis, usually it takes me a few hours to complete the report, but we'll do that in the next session, or I'll probably record it.
Okay, at a later time. So I don't see any more questions regarding this case. So maybe you go to the last case for a couple of minutes.
Okay, so the last case, let me show you. So this is, I don't know why it's taking a lot of time to load, but anyways, this is this patient. This is a 67-year-old male, and he had a fracture L4, and he did posterior fixation, posterior lumbar fixation. He was doing really well. Then I think he had a traumatic injury. He fell on his buttocks, and after that he was complaining of back pain and sacral pain. So he was referred to, he did an x-ray, supposedly when nothing was wrong. So he was referred to do the scan to identify pain generators. And as I remember, they did not expect to see any kind of findings. I'm gonna start with the sagittal images. So here you have the lumbar fixation, and you can see that there is intense uptake over here. These are the sacral screws. We have intense diffuse uptake along the sacral screws. Okay, this is taking a bit of time to load. I don't know why this case takes a lot of time to load. Anyhow, we have diffuse uptake involving the sacral screws. You have uptake over here in the facet. This is just an osteophyte. It is showing intense uptake as well here. And we have an uptake here, diffuse uptake around the vertebral body. And when you look at the CT, you can see there is a cystic lucency, a very big cystic lucency around this pedicular screw. And when we look at the other screw, again, we can see the same uptake and the same cystic lucency. Let's take a look at the axial images. So here you can see we have facet arthropathy over here. It is showing, they're showing uptake. These can be also pain generators. We have uptake here at the proximal aspect of the particular screw. This is not loosening. It can be related to stress over the screws. And here we have the diffuse uptake along these pedicular screws. We also have uptake here around the L5 screws. It's not diffuse. We don't see any cystic lucency. So this can be related to stress or overload over this segment. Okay, this is taking a bit of time to load. He had a redo surgery, so you can see the previous the tunnels for the previous screws. Okay, so now you can see here the diffuse, the lucencies around these screws. This is diagnostic for aseptic loosening or mechanical loosening. Now you have here this cortical interruption or lucent line over the sacral part, and we're gonna take a look at this, because this is what SPECT CT picks up. It can pick up multiple or multifactorial pathologies, and the patient can have multiple pathologies and not just one. So if you see the losing, you shouldn't just stop looking for any other abnormalities, or if you see an uptake, you have to try to explain it as much as possible. So here, what I want to show you.
It also looks like a fracture in the sacrum on the left side.
Yes, exactly. It's a fracture. This was an undisplaced fracture in the left part of the sacrum. I really don't know why this case takes so much time to load, even though I don't have a lot of images. Okay, so I just want to show you. Okay, it's still taking a lot of time. Anyways, so here we have, you have a lucent line over here. This was an undisplaced sacral fracture. And this is why you see this a very diffuse uptake over here, and to a lesser extent, the diffuse uptake around the right sacral pedicular screw. Nonetheless, we have loosening here, and we have a fracture over here in the sacral part. And the other thing that I want to show you, but I hope it's not gonna take. Let me try to reload it. Okay. This is now better. Here you can see a focus of very intense uptake here in the coccyx, actually. And when you look at the CT part, you can see here there is some kind of anatomical distortion, a cortical interruption. He actually had a sacral fracture as well, coccygeal fracture as well.
Yeah, I think it's still the sacrum, right? It's the lowest segment of the sacrum.
Oh, yeah, exactly. It's in the, okay, yeah, now I can see it.
So it's the lowest segment of the sacrum is fractured,
Yes.
and then we have the joint to the coccygium.
Yeah.
So there are two
uptake. So he had multiple pathologies. He had a fracture here. He had a fracture in the sacrum, and he also had mechanical loosening involving the sacral screws. He also had facet arthropathy, but I don't think, and they were active, but I don't think that's relevant in this case. So this is how I do the reporting. We have mechanical loosening, we have sacral fracture, and we have lower sacral or coccygeal fracture. And this was mechanical loosening. We have inflammatory facet arthropathy. I didn't put the early phase images because in the spine, we don't really need them. But we did it for this patient, and the early phase showed intense uptake around the facet joints. And so basically, this is what you need to learn. Adjacent segment degeneration, this is very important. And we do the SPECT CT to assess for adjacent segment degeneration. Basically, it is the facet arthropathy adjacent to the fixed segments. These segments are under a lot of stress, so they undergo accelerated facet degeneration, and they can be treated by targeted joint infiltration. And the patient usually, if the SPECT is positive, they're gonna get pain relief. If the SPECT is negative, they're not gonna benefit from any kind of targeted joint infiltration. I just want to show you. This is what I want to show you. So you can see here the fractured, the non-displaced sacral fracture. It's actually going through the trajectory of the pedicular screw. This was actually missed on the X-ray, and the loosening as well. The cystic lucencies were missed on the X-ray as well. So it's a really nice case. You have multiple pathologies, and you can diagnose all these pathologies in one session and under one camera. You don't need to do multiple images to get all of these diagnoses. I think by now we finished the cases. So do we have any questions?
So I think this last case, clearly the fracture is, you cannot really detect it on X-rays. So you need some things like CT or SPECT CT. So this, there's no other way. On the other hand, the lucency around the screws, they should show up on the X-ray.
Yeah, they're very big.
Yeah, great. So it's great. We had quite some attendance today, about 12, 13 people joined. Thank you for presenting the cases. I will briefly show our academy. So we need to remove this one, add this one. So this is the academy that most of you know. That's the Nuclear Medicine Academy. And what we have now 5 collections here in the free plan with the approach to laryngeal tumor as a short video. We also have the first part of the lymph node atlas here and the introduction to tracer uptake. and a collection or two collection of cases that we will expand in the future. And also we have this anatomy section, which we now split into the general nuclear medicine section and anatomy, because we have now the typical anatomy here, but we also have the Sestamibi lecture, which is the newest one, and there are two more coming for PET-CT preparation. And I can only recommend to subscribe to this Nuclear Medicine Academy. It's growing. Ziad is very diligent to record new stuff very fast. Has a lot of knowledge. It's only 20 euros per month, or even only less amount if you pay yearly. And I can only recommend to approach this academy, and also, of course, Berlin Case Fair as the larger academy where you also see musculoskeletal cases, MRI cases, etc. Great. So I think it was a good hour with you together, and wishing you the best for the next 4 to 5 weeks. And after that, we meet again and present more cases. Thank you. Great. See you next time. Bye-bye.
Bye. Thank you. Bye.